So we are getting started with the introduction as well. So good evening, one and all present here. I am Mona Lisa from Clarinet, the designated session assistant for the seamless interaction. Clarinet is India's foremost trusted and widely used digitech platform, offering multiple enriching services exclusively for doctors. We are very delighted to be a part as a digital partner for this event organized by Society of Oncoanesthesia and Perioperative Care, and today's session is all about stress response to surgery, implications for the oncoanesthetist. Thank you for your patient listening, everyone. So let us get the session underway, and I would like to welcome Dr. Anjali ma'am to take the session forward. Over to you, ma'am.
Good evening, everyone. Welcome back from the festive season. I hope you all had a lovely Diwali. It gives me great pleasure to introduce today's topic, which is stress response to surgery, and to welcome Dr. Upadhye, who's chairing this session. For those of you who know him well, Dr. Upadhye was head of Department of Anesthesia, Critical Care and Pain, Tata Memorial Hospital. May I have his introductory slide, please, Mona Lisa? He's currently the HOD of anesthesiology as well as critical care at the Asian Cancer Institute, Kampala Hill Hospital. And he also is the secretary of the ethics committee of there and director of the academics. That is his role in Kampala Hill Hospital. He also works as a consultant oncoanesthesiologist in Breach Candy as well as Raheja hospitals. And as you all know, he has a special interest in thoracic anesthesia as well as in intensive care. I would like to welcome you, sir, to chair this session and introduce Dr.
Thank you. Thank you very much, Anjali, for inviting me to chair this session. An important topic all of us know. And I think Dr. Aparna Date is very capable and experienced anesthesiologist who will talk on this subject. She is MD and FRCA both. And her current designation is she is a consultant in PD Hinduja Hospital and Medical Research, the CAR unit, and she is also pursuing her MSc in Perioperative Medicine. She started her career as a lecturer in St. GS Medical College and followed by Padma Shri Dr. D.Y. Patil Medical College. I know her since her Tata days. She was assistant professor and consultant there. Now, her next assignment was at Kokilaben Dhirubhai Ambani Hospital and Medical Research Center. She also has been trained in UK. Her special interests are thoracic anesthesia, difficult airway and perioperative medicine, and of course, stress in anesthesia or surgery. Now, this is an extremely important topic. The surgical stress. Many of my colleagues tell patients that we are evaluating you from the point of view of whether you can tolerate the stress of surgery and anesthesia. Then I started correcting them. The stress is by surgery and not by anesthesia. Anesthesia abolishes it. The job of the anesthesiologist is to get rid of the stress which a surgical trauma may cause and prevent the patient from getting into cardiovascular complications and slightly longer term multi-organ dysfunction problem because of catabolism. So I think the responsibility of the anesthesiologist is immense if we take it seriously, that we have to somehow manage to obtain this stress so that the patient's recovery is facilitated. And for this such an extremely important topic, I would now request Aparna to take over this session and give her lecture.
Thank you, sir, for the kind introduction, and thank you, Anjali, for giving me this opportunity to talk on this platform. I'll just share my slides. Is that okay now? The slides?
Yeah, sure.
Yeah, right. So after hopefully everybody has had a stress-free Diwali, we will go on to the stress response to surgery. As sir rightly said, it is a very important topic and it is not very well understood among the surgical colleagues, intensive care colleagues, and lot of anesthetists themselves. But it needs to be highlighted. And why is it so important? Because the number of surgeries that are being performed globally are huge. If you see at the WHO numbers of 2012, there were about 300 plus million surgeries which were performed in that year alone, of which 1 to 4% patients died following surgery, which is quite a significant number. 15% of the patients suffered morbidity of some kind, and about 5 to 15% had to be readmitted following discharge. Now, 1 to 4% means obviously it is pretty obvious that the lower numbers are in more developed countries, more resource-rich countries. They have lower numbers, and the poorer countries have higher numbers. So that's how your numbers go. To put it in perspective, the number of people dying from major surgery in the year 2012 was about 8 million, which is quite a significant number, comparable to people dying of other injuries or cancer surgery. But not enough resources are put in to deal with this situation, though it is a global issue. Just like the resources are put into dealing AIDS or cancer, not enough resources are put into these management of or prevention of deaths following surgery. So there are multiple other studies, cohort studies, which have been performed in the European countries. There was a cohort study which assessed in different European hospitals more than 40,000 patients. Again, they had similar numbers of 4% mortality rate. International study of surgical outcomes. These included all kinds of countries like middle, low income countries and all. And their aim was to look at the number of patients who develop complications after surgery and how many of those patients died. So after developing complications, whether you're able to rescue them or not, that is a failure to rescue if you can't treat them after complications. Most of the resource-rich countries are able to salvage patients who develop complications, whereas the numbers in lower income and middle income countries, that number was higher, how many they could rescue after developing complications. So that is something important that we need to look at. Indian data, as always, is limited. The only paper I found was from Vandana Agarwal and her colleagues from Tata Memorial. They were to participate in this ISOS study, but the number of centers from India were only 3 and they needed minimum of 10. So they have published their data in another journal. Again, the 3 centers, they were tertiary center, Nimans, Tata, and some other center in Gujarat. So they don't represent the Indian numbers, but a broad outline, 2.4% mortality, about 28% developed complications, of which 8.8% died. So this is something that we need to look at. If you see, why do the patients die? There are very few patients who will die on table. Very rare situations where you have massive blood loss, anaphylactic shock, or maybe lost airway and things. Most of the patients will die in the period following surgery, maybe 30-day mortality numbers and all. That is something that we are looking at. And why do they die? They develop kidney injuries, lung infections, ARDS, cardiac events. The most common thing causing morbidity and mortality after operations is the cardiac event. So these are all the complications happening in organs which are distant from the site of surgery. So what happens exactly? As perioperative physicians, we need to understand what exactly is happening. Whatever happens, this is just a slide. I don't mean to go into this slide. It's just, I want to try. There's a complex interrelationship between the different processes that happen following surgery. They are triggered at the time of the surgical insult. You have neuroendocrine response, metabolic response, immune response. So, and these are all interrelated processes, which maybe we worsen by our interventions or we can improve by our interventions. But a lot of things are happening following the surgical insult. And this is the thing which leads to the post-operative complications. So the normal response of an organism to any injury, whether surgical or other injury, is an inflammation. We have studied inflammation more in terms of an infective pathology, like our Robin textbook in pathology and all. We were taught about inflammation following an infective pathogenic invasion. The same kind of response is developed after a sterile stressor, like maybe a surgical injury, trauma, burns, patients being on cardiopulmonary bypass for a long time, and even ischemia reperfusion injury. All these trigger the same kind of inflammation that happens after a pathogenic invasion. The purpose is to limit the tissue injury, try and bring back the body to normal homeostasis, and it's a normal physiological process of the organism. What happens? I mean, the immune system, what does it do? Immune system is geared to identify the foreign antigens and the foreign tissues and fight against it. But it is also designed to recognize the harmful products which are released from the body itself, from cell. These are known as alarmins. Following the damage of the tissues, there is release of molecular some proteins and things which are released into the blood system, which are harmful. They are recognized as harmful by the immune system. And they elicit the same response on the macrophages receptors, which are present in the macrophages, neutrophils and things, similar to the pathogen-associated molecular proteins. So apparently there is some mitochondria are evolutionary derived from bacteria, and when they are released into the blood system, they evoke a similar kind of response. I mean, it's a vast study in itself, but broadly, this is what happens. When the tissue injury happens, the substances are released into the system, they stimulate the immune system. Now, these stressors, these damage-associated molecular patterns, they stimulate the immune system to generate an inflammatory response. The purpose is to fight the injury or try to bring back the body to normal process. It has to be limited at some point. The inflammation cannot go on and on. So the body has a natural process where a counter-inflammatory or anti-inflammatory process sets in after some time, and it tries to balance the inflammatory process and brings back the body to its normal physiological state. If there is an imbalance between that pro and anti-inflammatory response, then you have a problem. You have extensive inflammatory response, you have a systemic inflammatory response kind of a pattern. If there is a deficient response, then maybe these patients go towards infections and sepsis and all. So the balance is very important. That is your body's response to the stressor. How does the immune system work? We have our innate immune system and the adaptive immune system. Innate immune system is the one which we were born with. We have some immunity in our body, which is non-specific. It is not related to the specific antigens. It is activated immediately after exposure to the alarmin or whatever is harmful to the body. It is mediated by macrophages and neutrophils. They migrate to the site of injury. T lymphocytes, the NK cells, these are the most important cells in fighting cancers and infections and harmful things. The NK cells are the kind of lymphocytes which are responsible for apoptosis of the damaged cells, neoplastic cells, and the virally infected cells. So they are all activated, they reach the site of injury. This is an immediate response. Now, these antigens are engulfed by those macrophages and neutrophils and presented to the lymphocytes, which then activates the adaptive immune system. And they respond specifically to that kind of insult. This sets on a bit later on. But this kind of cell-mediated immunity is said to be depressed by the surgical stress. And that affects our wound healing and is responsible for what we talk about a lot of these days about cancer recurrence and things like that. That is because of the impairment of the cell-mediated immunity in the perioperative period. Again, these neutrophils and macrophages and all, they release the cytokines. These are small molecules which are released from neutrophils, macrophages. You have pro-inflammatory cytokines and anti-inflammatory. I'm making it too simple. It is a bit more complicated. This is, I'm putting it a bit simplistic so that it makes sense. So body releases both pro-inflammatory and anti-inflammatory cytokines. We are familiar with interleukin-6 and TNF-alpha and things. These are the pro-inflammatory ones. Excessive production of these is when we see the systemic inflammatory response syndrome mimics sepsis in all ways, but there is no infective pathology. And the anti-inflammatory interleukins and all are secreted later on. They are the ones who are responsible for limiting the inflammatory process and trying to achieve some sort of balance between them. How easy or how difficult is it to maintain that balance? That is something that we will look at, or maybe whether we can do anything or not needs to be seen. Next is the release of acute phase proteins. These are again stimulated by cytokines produced by the hepatocytes. You have CRPs and D-dimers and all. These are all markers of the inflammatory process or infective process or inflammatory process that is happening perioperatively. Usually, CRP and interleukin-6 are the consistent ones which we use as markers for how the infection or inflammatory process or the surgical stress response is developing. Each of these have their own times when they peak and when they start coming down. And they are used as markers to assess how the patient is recovering. We can also use these values to assess whether our interventions, if we are doing some interventions to try and limit or modify the stress response, whether it's working or not. Interleukin-6, CRP, these are the things that are monitored usually. Next is, I'll talk about the neuroendocrine system. Now, what happens once the cytokines are released, they cross the blood-brain barrier, reach the paraventricular nucleus in the hypothalamus. again, hypothalamus, this paraventricular nucleus is responsive to inflammatory process, hypotension that is happening. The pain responses, which are transferred via the vagus and other pain pathways, they are relayed into the hypothalamic system. And the neuroendocrine system is triggered. So hypothalamus controls both the anterior and the posterior pituitary. It also has an influence on the sympathomedullary adrenal system. So by its influence on the anterior pituitary, through its releasing hormones and all, it stimulates the release of ACTH, which then goes on to work on the adrenal cortex, and cortisol is secreted. Through the posterior pituitary control, it goes on to stimulate the secretion of arginine vasopressin, or ADH hormones, which goes on to act onto the collecting ducts. Again, it has effects on thyroid hormones and prolactins, but clinically, those hormones are not they haven't seen to be causing any problem to the patient. It's the cortisol, vasopressin. These are the hormones which mainly affect the outcomes. And through the activation of sympathomedullary system, adrenaline secretion is increased. Now, adrenaline itself causes sympathetic stimulation, increase in systemic vascular resistance, increase in blood pressure, and all those systems. It also has its metabolic. So all these hormones have their metabolic effects also. Vasopressin will cause salt and water retention, increase in the intravascular volume. Cortisol, it has its increase in the sugar levels and things like that. The metabolic effects translate into hypermetabolism, hypercatabolism. So surgery, perioperative period is basically a hypercatabolic period. There is mobilization of energy sources so that the body can recover. The body needs the easily usable energy sources to recover from the injury. So in the liver, you see glycogenolysis, skeletal muscle breakdown happens, proteolysis, fat reserves are mobilized. So basically, it goes into a recovery mode. The sympathetic stimulation acts not only on the systemic vascular resistance and things, it also stimulates the renin-angiotensin system. It stimulates the glucagon release through the action on the pancreatic alpha-2 receptors. Insulin is inhibited. Now, insulin is our only anabolic hormone, and that release is reduced. Again, growth hormone secretion, that also causes a bit of insulin resistance. So we are in a state where we are in a hyperglycemic state. We have insulin resistance. We have salt and water retention, and a lot of things are happening here. Some beneficial, some not so beneficial. So just overall, surgery is a catabolic state. There's protein breakdown happening. Sympathetic stimulation is happening, which is not some patients may not be able to tolerate if they have cardiac problems and all. Muscle breakdown is happening. All these things have to be at the back of the mind. We don't see these things, but we have to be understanding that all these things are happening inside the system, and we have to proactively be looking at it and trying to modify this response. Can we really control it? Does every patient respond similarly? That is again a problem. For the same surgery performed by the same surgeon, two individuals will not react similarly. There is a definite genetic variation in how people respond to stress. It's seen with infection also. We have seen family of COVID patients. One had no symptoms, one had mild symptoms, and one succumbed to COVID. Similarly, surgery, how patients respond, there is a lot of genetic variation in how they will respond to the stress of surgery. Definitely, the magnitude of surgical insult influences how much stress response is elicited. So this is more relevant to us who are into oncoanesthesia and dealing with cancer surgery. Most of them require extensive tissue dissection, lymph node dissection, radical resections, and also the tissue injury in all these patients is much more than in the normal non-malignant surgeries. They also are having nutritional deficiencies, chemotherapies, and things like that. So they're at a lot more risk than any other patient. People who are older or frail, they have a higher inflammatory response following surgery, apparently due to the dysfunction of hypothalamo-pituitary axis. The negative feedback mechanism that exists following release of cortisol, that is blunted in older and frail patients, people with even depression and anxiety. So they tend to have a greater inflammatory response following surgery. People who have had cardiovascular deconditioning due to the cardiotoxic chemotherapy, people who are not mobilizing much due to joint problems and things, cardiac issues, they tend to tolerate surgery poorly because they are not able to deal with the stress response of the surgery. So it is trying to modify the stress response. This concept has been around for a while. I think late 1980s, Dr. Kellett and all tried to form pathways of enhanced recovery pathways, where they tried to give perioperative pathways. Basically, the aim was to modify the stress response, try and improve the metabolic response that follows surgery. The idea being to get the patient back on feet as early as possible, reduce the length of hospital stay, reduce the ICU stay. And it was not that one particular factor was to be changed. It was multiple issues you had to address, and small changes in every part of the pathway, you could achieve better results. So there was always, maybe more than 20, 30 years, we've been trying to improve the perioperative pathways to try and improve the patient outcomes. What can we address? I mean, there are more than the things I've listed here. We can address more than these things, but this is something that I'll spend few minutes on each of them. And anesthetic drugs, nutrition, all this, I'll give few minutes to each. Anesthetic drugs are being talked about a lot now, more so in terms of cancer biology and the effects of anesthetic drugs on cancer recurrence and metastasis and things like that. I'll not go into each and every drug, but basic principle behind it is that there is suppression of the NK cell activity, and there is immunosuppression, which favors the metastasis of the malignant cells which are disturbed at the time of surgery. And that is what leads to cancer recurrence and metastasis. Present evidence seems to lean more in favor of the intravenous anesthetics because they seem to have a better, they are favorable in terms of immunosuppression. However, no definite guideline yet, or the jury is still out where we can say that we have to use TIVA only against volatile anesthetics, but evidence seems to be more in favor of TIVA, use of TIVA propofol and things to prevent cancer recurrence and metastasis. Nutrition. Now, yes, this is a definite enough evidence is there now that nutrition and reducing perioperative fasting times will improve the outcomes after surgery. Patients who anyway come with malnourishment, protein deficiencies, iron deficiencies, they tend to have a poorer response after surgery. Insulin perioperative period is a period where there is insulin resistance. It is that, as I said, that is something that we need to be addressed. And if we are giving carbohydrate drink the night before and the morning of surgery, we can have the patient in a well-fed state, physiologically well-fed state. The number of patients who develop insulin resistance and all is much less if they are fed this carbohydrate drink and their excessive starvation is avoided and all. So there is definite benefit from the carbohydrate drinks and avoiding excessive fasting periods. The surgical approach. Again, we know that more the trauma of surgery, the more extensive the surgery, the greater is the stress response. And it has been proven in multiple studies that laparoscopic surgeries, robotic surgeries have better outcomes rather than the similar kind of open surgeries. Cochrane review, everything has shown that the interleukin levels are much less with the robotic and laparoscopic surgeries. And definitely there are more benefits of minimally invasive surgery. Now, fluid management. This is something very important. I mean, we've been debating over this years and years. What is the correct fluid to give? How much fluid to give? What is the right amount? Still, we haven't arrived at any decision about how much fluid to give. Perioperative period, as we said, is a time when there is going to be salt and water retention because of the effect of ADH and aldosterone. There is glycocalyx damage at the capillary level, so capillaries are leaky. So you have a situation where there are tissue edema and at the same time intravascular hypovolemia. Both reduce the oxygen delivery to the tissues. Both are harmful. They further trigger the systemic inflammatory response. So what is the right thing? Presently, the consensus guidelines are to have a individualized tailored approach for fluid therapy, use perioperative fluid, goal-directed fluid therapy, judicious use of crystalloids, inotropes, vasopressors were needed, and if needed, even blood to improve the global oxygen delivery. Basically, the aim is to improve the oxygen delivery to the tissues. So use an individualized approach based on maybe flow tracks, stroke volume variation monitoring, cardiac output monitoring with the devices. And that at present seems to be the right way to give fluids. Having said that, improving global oxygen delivery does not always mean that you improve the local tissue perfusion. I mean, there can be a variation between what oxygen delivery is happening at a global level and individual tissues, because microcirculatory failure can happen, especially in a stress situation. When you have a compromised situation, the gut blood supply is the first one to be affected. The gut is some non-essential organ. So the gut mucosal blood supply gets compromised before heart and brain. With that, there is a loss of endothelial integrity, release of the endotoxins from the bacteria, the commensal bacteria, which are present in the gut, and they lead to endotoxemia, which have serious implications, systemic inflammation. There are studies where they've used selective digestive decontamination to reduce the bacterial load in the gut to try and reduce complications, and there are some positive results from it. Even anti-endotoxin therapies are being used, still in experimental phase, but they're shown to be of benefit in this situation. Analgesia. Now, this has been studied over years and years, that providing good pain relief blunts the stress response to surgery. Regional anesthesia is the best one, and there is enough evidence that giving regional anesthesia, blocking the pain impulse before it reaches the brain, helps in reducing the pain response. Thoracic epidural analgesia is the one which is being studied the most. There are meta-analysis and multiple papers which have shown that in upper abdominal surgery and thoracic surgeries, then it has been able to reduce complications. Pulmonary cardiac complications have come down. The cortisol and catecholamine levels are much less following use of epidurals in these surgeries. However, some studies have shown that cytokine response is not altered. The inflammatory cytokine levels are still the same. And maybe due to logistic reasons or technical, it is a skill that is hard to learn, or maybe you don't have enough resources that the patient needs to be observed in high dependency unit, providing pain services and all. Somehow it has gone on to fewer people are using it. Or maybe it is that the minimally invasive surgery has come up. Most of the VATS procedures or laparoscopic procedures are being done more. So the need for epidural is going down. And generally, field blocks and facial plane blocks are gaining more popularity. Blocks are everywhere now. So facial plane blocks and single shot intrathecal opioids, they are gaining in popularity. They are the upcoming techniques. However, the number of studies which have proven benefits in terms of outcomes are more with thoracic epidural. So these are still newer techniques, and not enough studies have been done for us to say that, yeah, they improve outcomes. Whereas the studies are there for thoracic epidural analgesia. But maybe in the future, we might have more evidence to support their use. Opioids, the other backbone of our management in pain management in the perioperative period. Now, the trend is to go away from opioids. We are now more in terms of opioid-free analgesia and all. I think even on this platform also, these discussions have happened where, is it really possible to give an opioid-free anesthesia? Not really practical. We still do use opioids. They act on the mu receptors, and high doses of opioids have been shown to reduce the ACTH and cortisol secretions and bring down the stress response. Morphine seems to have got a negative publicity now because it impairs the monocyte and neutrophil function, and it is implicated in terms of tumor growths and things like that. Apparently, the synthetic opioids are better. Still, there is no firm guidelines that you should or should not use, but evidence is more towards using synthetic opioids rather than morphine in terms of immunosuppression, cancer recurrence, and things like that. Another thing is now autonomic balance. Now, sympathetic response is harmful and causes more cardiac complications and things. And people who have a better parasympathetic flow seem to have a lesser stress response. So if you can tilt the balance towards the parasympathetic flow, then the sympathetic discharge, then the outcomes are better apparently. And this can be done by meditation. Meditation, they are studying a lot in terms of cardiac patients also, where you can reduce the sympathetic outflow and improve patients who have cardiac problems, whether their outcomes can be improved. Exercise, again, improves the autonomic balance. So meditation, exercise, beta blockers, all are being studied, whether they can improve the outcomes after surgery. Beta blockers, again, both positive, negatives. There are beta blockers will reduce the sympathetic flow, but then there have been complications with perioperative use of beta blockers of stroke and hypotension and things like that. So all this is still being evaluated. No firm conclusions yet. So to broadly, I mean, there is no definite recipe where we can improve outcomes or reduce the surgical stress response. What one has to remember is that even though the brain is anesthetized, it is asleep, it is still responding to the surgical stress. The processes are still happening. And the stress response is a complex and interdependent process. Multiple systems are involved: neuroendocrine, metabolic, inflammatory, immune system. Everything is involved. They are all interdependent. Modifying stress response can improve perioperative outcomes. So rather than dealing with problems after the complications after they occur, which is much more expensive and more difficult, if we can target it before the complications happen and small changes at every level, maybe we might be able to improve perioperative outcomes. So it is just a topic for thought, no definite recommendations, recipes, but something that we need to keep in mind and work on it. And these are my references, and thanks a lot for your attention.
Thank you, Aparna. Wonderfully explained the concept of how stress is generated and how one can do something about obtending it. Anjali, you can access the chat box and find out if there are any questions before we discuss.
So at the moment, we don't have any. I would like to request the audience if they have any comments to make or any queries at all, please put them in the chat box. Otherwise, we can go ahead with the discussions.
A balanced anesthetic technique, which is the concept existing for years now, consists of a very important component, that is pain. And pain is one of the biggest trigger to cause stress. Yeah? So I think the right amount of analgesic drugs, whether you use opioids or opioid-free anesthesia, the right amount of analgesia solves many problems of stress-related problems. So, do you have any advice how to use narcotics? Because narcotic is one of the agents which is so universally used now, and I have seen people using narcotics from the just arbitrarily, say 25 micrograms of fentanyl at lowest end to high levels of 600, 700 micrograms for a major surgery. So how do you titrate your narcotics?
I mean, first preference would always be a regional anesthesia to blunt the response of stress. So wherever possible, you would try to give epidural or a block of some kind to blunt the response. More opioids, as they say, there is no ceiling dose for opioid. You have to titrate it to response. Either patient is pain-free or you develop side effects, one of that. Under anesthesia, that is difficult. I mean, you can't ask a patient whether he's pain-free, and side effects of respiratory depression and things don't apply under anesthesia. So the traditional methods of using heart rate response and blood pressure response to pain, that is something you would use, or more complicated monitors like we in Hinduja Khar, we use the Conox monitor, which monitors the depth of anesthesia as well as the response to the noxious stimulus. So you can target the objective numbers on that. But in an awake patient, yeah, obviously it would be ceiling. There is no ceiling dose. You would titrate it to patient's response or side effects. And under anesthesia, it would be more in terms of textbook numbers of so much microgram or milligram per kg, and then titrate it as per your heart rate, blood pressure response.
Right. Right. Now I see some 3 or 4 questions in a chat box. So Anjali, can you go one by one?
Yeah, we have one: role of steroid in major oncosurgery to reduce stress response. Any comment on that?
Yeah, I mean, steroids are talked about a lot now. People are using steroids, especially dexamethasone, as an anti-inflammatory, anti-emetic. more commonly as an antiemetic, and even for pain relief. TKRs and THRs, they are using dexamethasone. It helps to reduce the inflammatory response and things. So dexamethasone is being used. The worry is about immunosuppression and whether they'll have higher chances of infection and cancer recurrence and things like that. The studies as of now, presently they 0.05 to 0.1 milligram per kg of dexamethasone they are calling as a low dose, and with the low dose they have not shown any higher chances of infections and cancer recurrence. But the studies as of now are not in any favor of dexamethasone being of any benefit. They have shown that there is no side effects or worse effects from dexamethasone. Some studies have used methylprednisolone also, but again, they are more in terms of no major side effects or no major downside to it. But benefits, there are no studies which have shown any benefits of using steroids for preventing cancer recurrence or anything like that.
Right.
So present studies are not saying that use steroids for any benefit.
Anjali, next question.
Is there any, I just wanted to continue with that. What about the detrimental effects, as far as steroids go, about infection and all? I mean, really,
Outcome-wise,
not
they haven't
every-
shown any worse effects, because infection rates or anastomotic leaks or there are no worse effects by using dexamethasone in the dose that we are using for antiemetic purposes or anti-inflammatory, like in TKRs, THRs. Those kind of doses, there have been no worse effects. So it is not detrimental.
I agree. What is the next question, Anjali?
I just thought that there is one thing about these steroids. Sometimes when you have patients who are not responding appropriately to an insult, um, especially in India, do you have an incidence of abdominal coughs and suppression of the adrenal
suppression?
So sometimes steroids are beneficial in
Yeah,
that.
in sepsis and where you're suspecting adrenal crisis, you would give steroids when your patients are not responding to vasopressors and all. That is something is recommended, to use high dose of steroids when you have really in patients in septic shocks, not responding to your inotropes. That is something you would use, but not as a prophylactic from cancer recurrence point of view or infection point of view.
Yeah, that is true. I think, Aparna, you can stop sharing your screen so that
Okay.
videos. There also seems to be another question in the chat box. There seems to be a move in the West, particularly in the UK, to move from inhalational to total intravenous anesthesia. Do you have any personal experience with regard to stress response in this area?
I have seen that especially in the cancer hospitals, they are going more towards TIVA because of this effect of inhalation anesthetics on the cancer biology. So yes, there is definitely a trend towards TIVA now. But I'm not involved in research, or I haven't worked with people who are doing research on this anesthetic drugs and cancer biology. But the people who are doing research, I mean, obviously I've read it in the literature, and the studies seem to favor propofol over inhalation anesthetics. I'm not a researcher, so it's not my direct experience, whatever I have read.
I think the replacement of inhalation anesthetics by TIVA is aimed at preventing cancer recurrence, right?
Yeah.
Got nothing to do with the consideration of obtending stress.
No, it is the...
So I think as far as the stress is concerned, there should not be any difference between inhalation agents and TIVA. You actually explained in one of your slides, there is a slight advantage of TIVA over inhalation agents as far as the stress response goes, but that's quite minimal, right?
No, when we talk about stress response, we also include the immune response to surgery, which includes your T lymphocytes, NK cells and all. So your anesthetics, inhalation versus propofol, that is your effect on the NK cells. So it encompasses, and there's a bit of overlap in that.
Yeah, the immunosuppressive actions of inhalation agents can be probably avoided. So the stress response is indirectly gets a help from.
It's a similar mechanism, yeah.
Similar mechanism. Right.
We have two questions here. So one says, is anybody practically using preoperative meditation for surgical stress modification? I believe this pertains to the patient doing meditation.
It is only in the studies. It is only patients or doctors. We all need to meditate before going to OT. So I think we should all try it. But from patients' point of view, it's only in the studies that people have tried doing all this to uh, uh, achieve autonomic imbalance, to sort out that. So it is all in studies for cardiac patients and surgical patients. These are all studies. No,
I'm not
I don't
really
think
aware
anybody does it.
of, Dr. Bhatti has asked this question. I don't know whether just 15 minutes of meditation prior to the event, what benefit it would have. But there is some evidence which has shown that if there is consistent practice of meditation, then there is some neuroplasticity that occurs, and over 6 weeks or so, it gives some benefit as far as the stress response is concerned. That might be something to think about. There are some studies supported by MRI evidence. And then we have a follow-up question. What about the stress response in the operating team?
Part
What?
of our job.
We all have to do meditation. That's all I can say. We don't want to go on beta blockers and things. Meditation is simple.
If you provide good depth of anesthesia with good analgesia, I think you yourself become stress-free by looking at the monitor, which will show you a normal pulse rate and a normal blood pressure.
Yeah. I mean, a
You-
surgeon can make out when things are, when he sees a calm anesthetist, they know that things are going wrong. And if
Mm,
it is, I think, yeah, the demeanor of the anesthetist shows how the patient is doing.
That's right. That's right. Practically speaking, I'm touching a little raw nerve here. So we have lots of nursing homes in various cities in this country, and providing stress-free anesthesia, taking care of good pain relief and good depth of anesthesia. An anesthesiologist hopping from one nursing home to another is sometimes forced or inclined to underdosing the patient, to get the patient awake on the table and rush to another place. This was when I was in USA in 1995. I was working, or I was observing what they do in Memorial Sloan Kettering. They told me that even nursing homes of USA, the practice of underdosing the patient is quite rampant because they have to move from one place to another, the freelance anesthesiologist. But institutional practice is a different ball game, because if we concentrate on providing the good depth of anesthesia and good stress management in a patient, good analgesia, it is likely that you may have to spend a longer time with the patient before he or she can be wheeled out of the operation theater to recovery or wherever. And Dr. Wilson was the head of PACU at Memorial Sloan Kettering. Memorial Sloan Kettering has a very high load of patients, and they have to finish their list as fast as possible. So what they do, Professor Wilson told me that the anesthesiologist need not compromise on anything. The patient is never reversed in operation theater. The surgery is over, the patient is shifted on ventilator to a PACU with 30 beds and 30 ventilators, big infrastructure, and the anesthesiologist posted in PACU will see that the patient recovers reversed, leisurely and safely, without hurrying up and without wasting the time of OT. But the anesthesiology department of that center in 1995 had envisaged that problem before, that to run the list fast, you don't have to underdose the patient and get the patient up and about on the table for the next case to start early. So, but I think this is a point in our country, nursing home hopping anesthetist is, he's handicapped by the time he could spend on the patient and the time he requires to travel from one place to another. And God forbid he may underdose the patient and have the patient up and about, but would traumatize the patient. I think this
I'll
is
just,
something which need to be addressed.
yeah, I mean, you're right in what you said, but in their favor, I'm talking in terms of favor of private practitioners, they tend to do a lot of cases in regional blocks. Very few private
That is right.
practitioners. So in a way, they are helping the patients by giving a stress-free anesthesia, because most of their cases they would try and do under blocks, spinal, this, that, and they avoid GA as much as possible. So that is one point in their favor. But I'm sure when they give GA, they are underdosing. And secondly, about another anesthetist extubating your patient, I think the anesthetist who's managed the patient, especially major cases, who has managed the patient all throughout, is the best person to extubate, because that anesthetist knows. I mean, he has.
I think we lost you, Aparna. You've muted.
Sound's gone. Sound's gone.
Yeah, we got back. Okay, Aparna, we can't hear you. I think, have you muted yourself by any chance? Well, Aparna is...
Hello, can you hear me now?
Yeah.
Okay. I don't know what happened. That audio went off. Yeah, so I don't know. I think the best person to extubate would be the patient who has managed the patient all throughout the surgery. But I suppose they are used to that pattern of working. So
90% of cases probably, even though major, are routine, right? With
yeah.
the same protocol followed. So
Yeah.
it doesn't matter if somebody else does your job at the end of surgery. Some of the problematic cases, it may not so happen, right?
Actually, I'm not sure what Sloan Catering does, but we did have this practice in Tata earlier where we did major cases, the patients were cold. And those, so this is not, you don't shift to PACU and immediately extubate them. You give them time to warm up to get back to the normal physiology that they were experiencing earlier. And so now we have much better warming equipment and monitoring equipment. But it was a practice to ventilate major surgical patients for a while after surgery and then let them gradually awaken and extubate them. I'm not talking about head and neck surgery and distorted airway. I'm talking about major coelomic surgery. So I think that practice, quite a few institutes may be taking up in a way for elective postoperative ventilation.
Yeah, I think
you had a medical reason for
it's the right way of doing things.
Because actually the expenditure of the cardio respiratory system is quite a bit. So a lot of their energy is dissipated as heat. So taking care of that aspect for some time until the patient warms up and sort of is completely back to the normal physiology might actually be beneficial from the stress response
Yes,
point of view.
it is beneficial. It is beneficial, but it's again a matter of infrastructure and expenses going into creating that kind of infrastructure.
But I also think only those institutes who are doing these major surgeries are practicing this. Meaning, not run-of-the-mill cases. Run-of-the-mill cases, obviously, as Aparna said, the person who does the case extubates the patient. Yeah. But it's only these major cases who are handed over to the ICU for a short term for ventilation, that sort of.
Nowadays, a lot of nursing homes are doing major and supra-major cases, even onco cases under GA, and they are doing well. And they are all competent people amongst us, competent people among surgeons, and they see this practical difficulty because they may not be able to have that kind of infrastructure to pursue this path of ventilating the patient in the post-operative period. So they are doing a lot of balancing act. Means my salute to them, but at the same time you cannot forget that some of the patients may be at the receiving end of underdosing. In this. So I think better infrastructure at nursing home levels. Nursing homes 25 years ago and nursing homes now, there is a large difference. There is definite progress in
they have much better monitoring and everything. And there's one more practice that has come up where you use segmental
spinal.
Yeah. So I think that is something that will that incorporates what you said earlier, that they're going in for regional. and taking care of areas where you would otherwise have gone in for general anesthesia. So moving on
Right.
from that topic, can I take up the next comment?
Yeah, please.
Does any patient undergo, so this is another psychological counseling question. Does any patient undergo professional psychological counseling preoperatively routinely, as oncosurgery per se impairs the psyche considerably?
I think this is the field that we need to get into now. Perioperative medicine is a field that is developing, where there are perioperative physicians who deal with the preoperative, intraoperative, and postoperative management of the patient. See, surgeon has only a limited time to talk to the patient. He's more into what the surgery is, what the complications are. But there's a lot more preparation that has to happen before the patient comes for surgery. And in UK, Australia, and all, now this perioperative physician, I said I'm doing an MSc in perioperative medicine. So few countries are offering this course where there is a separate specialty of perioperative physicians and they could be geriatricians, surgeons, anesthetists, whoever, different branches, who will prepare the patient for surgery, from psychological to physical preparation, like nutritional deficiencies, developing their preoperative fitness, like rehabilitation and things like that. And psychological preparation is also an important part, because that helps to reduce the stress response to surgery. Definitely, it has been proven. So this is something that we need to get into now. Those who are interested in perioperative medicine need to get into it and get involved. Whether we have enough resources at present to cater to this, because it is not just psychological counseling, it will also include rehabilitation, nutritional optimization. All this, patients have to be prepared before surgery, and this is a field which needs to now develop. And under your auspices, Society of Oncoanesthesia and Perioperative Medicine, we have to start developing this field and get ourselves involved, not just in the operation theater, but before and after the surgery as well. Because we transfer the... Yeah, sir.
Right. So I think that
not among the medical personnel, but a professional psychologist who counsels the patient preoperatively. And that kind of experience we had done in our Asian Cancer Institute, where the psychologist was not a doctor involved in day-to-day management of the patient. She was not a doctor, but a certified psychologist. And what we found was that these people profoundly lack the knowledge of oncology. They have no clue about what exactly happens in oncology. What is medical oncology? What is radiation oncology? What is surgery? What are the outcomes? What are the problems faced? They have no idea unless they get into a specialty and learn about oncology and then become a clinical oncopsychologist. This won't work. The question asked by him is probably referring to such kind of a person. Amongst us, perioperative physician is amongst us, right? But he's referring to a person who is from outside this field, but a psychologist.
Yeah, all that will need more resources. I mean, for the patient, we'll have to pay for the psychologist, we'll have to make the additional visits. For a cancer patient, they are already overburdened with the chemo and multiple visits to the hospital. So even rehabilitation also becomes difficult, because we are not able to patient is not able to access, either for financial reasons or for distances and somebody to bring the patient. So I don't know how we will get all this done, but it is necessary.
Yes.
So Rakhi Khemka from PMC Kolkata says that they have actually incorporated this into their practice, especially for vulnerable patients, like those who are suffering from breast cancer. They have a team of full-time psychologists and psychiatrists dealing with the pre and post-operative period, and also for long-term follow-up post-surgery. That's a very commendable initiative.
Very great. Yeah, really.
And I also think that there are institutes which are using this therapy, like play therapy, for pediatric patients. Not for everyone, but for pediatric onco patients. Not all of them come in for surgery necessarily, but they do come into the institute pretty. There are numerous visits that occur for chemotherapy and so on and so forth when they have liquid cancers. So Rakhi Khemka says that they have a decade of experience with this sort of discipline with the psychiatrists involved, and they do have a child psychiatrist as well. Thank you, Rahul.
Right.
And in the interest of time, I think we take just this last question.
Right.
Aparna Thakkar says IV's Hyalocard also has beneficial effects on the stress response as well as in cancer recurrence. Any comments?
Yeah, there have been studies in colorectal cancers where IV bolus followed by infusions have been used in colorectal surgery, and the recurrence rates have been low. So yes, IV lignocaine in studies have shown to reduce the recurrence rates in colorectal cancer. How many of us would be happy to use intravenous Zylocard? I think I can't remember the duration, how long they used it, but they have used it throughout the surgery in an infusion. I wouldn't be comfortable to use Zylocard all throughout the surgery. I would rather give a regional block. But if anybody has clinical experience, studies, yes, definitely it has proven benefit. But if anybody is using it clinically, I'm not sure.
We did try using it intraoperatively for a few cases, but we had issues convincing the intensive care people to continue it in the post-operative period. Dr. Abhijit Nair says that 24 to 72 hours lidocaine infusion has been used, which is true. So that requires the cooperation of the people who are looking after the patient.
Did they say any side effects from the lignocaine use or?
I have no idea.
No side
No
effects.
side effects. Okay.
No side effects.
Okay.
Any more questions?
No, I think we are also running out of time. So.
Okay. I think it was a wonderful presentation by Aparna. There is no, I think we all applaud her for that. She explained everything, the physiology, the underlying pathology, about stress, how to manage it, various theories, various concepts, and what all needs to be done to prevent this stress, surgical stress, so that the patient ultimately gets benefited in the shorter and the long run. This topic must be concentrated upon by all the anesthesiologists involved, and however stressful it may be, it should be addressed properly. The idea of using a combination of general anesthesia with a complementary nerve block or an epidural block is a great idea. In the absence of any nerve block, using right amount of doses of narcotics is a must. Must ensure most people will probably have the cardiovascular monitoring to guide them to the uses of their analgesics and inhalation agents and TIVA. They should be complied to you, and make sure that your patient remains stressful at the end of surgery and recovers beautifully. I think after this beautiful lecture, we all are enlightened at the end of it, and we thank you, Aparna, for that.
Thank you, sir.
I thank you, the audience, putting good questions, and Aparna for answering them competently. Thank you very much, Aparna. And Anjali, thank you very much.
Thank you, sir. I just wanted to make one comment.
Yeah.
I think the take-home message from Aparna's talk is that one slide where she said that it is your small adjustments at the correct time which sort of, keep your patient within the physiological limits. And for that, you have integrated approach, as sir has already said, about so many aspects that you need to integrate into your practice. Thank you so much, Aparna. Thank you, sir.
Thank you.
And
Thank you, sir.
many thanks to the audience as well for staying with us for so long. Hope you have a lovely evening. I'll hand over to Mona Lisa to conclude the session.
Thank you so much. So with that, we come to the conclusion, everyone. Thank you so much for extending us the opportunity to host the session today. I hope you all had a seamless experience with us. So with all your due permission, we are concluding the session over here and really looking forward to hosting you again. Thank you so much, everyone.
Back to semi-finals.
Thank you, sir. Thank you, Anjali.
Thank you. Thank you.